Magic. Magic. And good afternoon, everyone, and welcome to the afternoon session of our PerfWeb special series on cell salvage as a key blood conservation technique. I'm your host, Joe Basha, with PerfWeb, and we would like to thank Haemonetics for a very generous, unrestricted educational grant to bring you this special program, special series. We plan on doing several of them, hopefully even more than that afterwards. So we want to thank Haemonetics very much for this privilege and opportunity. Very important topic on the what I call transfusion management, self-salvage for that, but we can discuss that a little bit later. Some of my philosophical concepts of how we say things. I'd like to take a moment and introduce what is our really just esteemed faculty. Here in the studio with me and to my immediate right is someone who you've come to know in the PerfWeb series, Dr. Hany Samir. Dr. Samir is an assistant professor of cardiac surgery, critical care, and transplant quality, assistant professor of clinical anesthesiology in neurosurgery at the DeBakey Heart and Vascular Center, Houston Methodist Hospital, and that's at Texas Medical Center, Houston, Texas. Welcome, Dr. Samir. He's also the director of Telehealth HS Consulting. He is really I think at this point, a recognized expert in the field of telemedicine, as well as many other things, including autologous cell salvage and managing Jehovah's Witnesses. So we're really excited that you're here talking about this topic. And working with Dr. Samir and coming to us from all the way in Würzburg, Germany, is Professor Patrick Maybaum. He is a professor and director of the Department of Anesthesiology, University Hospitals Würzburg, Germany. He has published more than 200 journal articles and reviews in the areas of patient blood management and intensive care medicine. He's also the director of the German PBM, which is patient blood management. I'm assuming that's patient blood management is what PBM is standing for there. Dr. Maybaum, maybe you can clarify that. But autologous blood management, ABM, all of these things, very important. But I think that's very exciting. And it's really interesting to me that here we are some, 20 years later, and we're still not seeing the level of adaptation or adoption of autotransfusion in our practices. So I find that to be very interesting, and I'm really looking forward to your guys' lectures on perhaps why that is, and really emphasizing the import of autotransfusion as a component, an absolutely required component for any robust surgery program. It doesn't have to just be cardiac, and I know you guys will be talking about that Earlier you saw a QR code, and David can bring that up a little bit later. I don't know if he can do it right now, but please make sure you click that QR code so that you can do the evaluation on this program. There's a lot of things about this that you are going to want to tell us so that we can continue to bring you really good quality programming here and beyond. Okay, so that's very important. Also, this program is approved for 1.2 Category 1 CEU by the ABCP for those perfusion colleagues out there watching, but really our target audience is perfusion, but also anesthesiologists, surgeons, nurses, program directors, nurse practitioners, mid-levels of every kind. So please, neurosurgeons, orthopedic surgeons, so please share this with your friends and your colleagues because this is important data. I would like to just very quickly get Dr. Samir started. I think his slides are ready to go. No, Dr. Maybaum first. Okay. Yes. I always get this messed up. I am so sorry. Thank God there's somebody over there that is telling me what to do right. I know. So Dr. Maybaum, I believe we are going to be starting with you. Your slides are up, and if you're ready, sir, I will let you go ahead. But before you start, can you please tell us a little bit about where you're from? I gave a very brief overview of you, but really tell us a little more about you personally, where you are, the beautiful backdrop that you have there, what Germany is like to live and to practice. Just tell us a little something about yourself, if you would.
Hey, so thank you very much for the invitation and for the short introduction. So I'm Patrick Maybaum. I'm working as an anesthetist and intensivist at the University Hospital in Würzburg. I went to a medical school in Göttingen, and I worked in Kiel and in Frankfurt several years, and now I'm started with as a director a few months ago at the University Hospital in Würzburg. So I'm 42 years old. I'm working, I see a lot of patients with anemia, with problems with hemoglobin, with patient in the OR with coagulation problems, coagulopathy, and for the last 10 years we are focusing on blood conservation techniques, on patient blood management, and how to improve patient care, how to avoid unnecessary allogenic red blood cell transfusion, and probably that's the reason why I was invited, and I'm really happy and I enjoyed the first session. And I'm going now to talk about cell salvage systems, how do they work, and in the second part, after the talk of Dr. Samir, I wanted to talk about the role of cell salvage in the context of blood sparing techniques and patient blood management programs.
Mm-hmm. Oh, and Dr. Maybaum, if you could, and for those folks at home, if you look at the bottom, if you're on Zoom, if you look at the bottom of the Zoom, you'll see chat, you'll see raise your hand, and you'll see Q&A. If you want to raise your hand and ask a question, or you want to chat with the moderator, the Zoom moderator, you're certainly welcome to do so. That'll be Jennifer. And if you want to see what questions have been asked and or possibly answered, because Dr. Maybaum is really good at being able to answer questions on the fly. I can't do it. Thank goodness he can. You just click on the Q&A chat and it'll pop up. So Dr. Maybaum, please forgive the interruption, but I had to get that said.
Oh, I'm really happy and really thank a lot for this idea and comment. So if you go to the next slide, then here, ladies and gentlemen, I'm going to show you some pictures of my hospital, and here you see a bleeding patient after cardiac surgery, and on the next picture you see an OR after really trauma, an accident, and on the next you see a patient bleeding after major vascular surgery, and on the next slide you see that in some of these patients we are able to collect bleeding blood. We can collect blood in a reservoir as a first step, and from our point of view, this should be the standard in most of patients with massive bleeding or major bleeding or in any type of surgical procedure with a blood loss of more than 500 milliliters, just to avoid bleeding-associated coagulopathy or allergenic blood transfusion, and to improve the use of patients' own blood. If you go to the next slide, then you see that what is happening in most of our hospitals in Germany or in Europe. So in any patient on any surgical procedures where we have bleeding, major bleeding, blood loss, it is really easy to ask for allergenic red blood cell units. Red blood cell units are quite cheap, at least in Germany, and it's really easy to compensate bleeding patients with allergenic red blood cell units. And I mean, the key question is this the only way to treat patients, or can we go for other ways? And on the next slide, you see that a lot of hospitals are doing a different way. And here you see data for patients undergoing isolated primary CABG surgery. A lot of United States hospitals have been analyzed, and you see that there's a huge variation, and there are some hospitals who are quite good and can do CABG surgery without any blood transfusion or with really a minor part of patients, only 10 or 20% who receive allergenic blood transfusion. And at the opposite, there are a lot of hospitals who are doing CABG surgery and who transfuse almost every of their patients. So a huge variation. And the same is true on the next slide for patients undergoing orthopedic surgery. These are data coming from Austria, and here you see huge variations between different hospitals for the same type of surgery. So these are patients after knee and hip replacement surgery, and you see hospitals on the left side with a really low transfusion rate, and on the right side, hospital number 10 or 14, where you see that probably almost every patient receive at least 1 unit of red blood cell unit. So a huge variation, and I have no idea what is the underlying mechanism, but you see that most of physician hospitals are doing a different way. And on the next slide, you also see that transfusion of allergenic red blood cell units might be associated with major adverse outcome. We see, at least in a lot of observational data, we see an increased mortality rate, we see an increased risk of morbidity, we see an increased risk of infection, we see patients with transfusion reactions, and of course, any unit that you transfuse, from a blood donor that you are transfusing to a patient, is associated with costs. So these are really a lot of problems that are associated with allergenic red blood cell units. And on the next slide, you see that even the journal Nature has focused on this problem, and they are saying that if you save the blood of the donors, and if you keep an eye on the most important and most urgent patients, you probably save more lives. So the message is save blood, and think about if transfusion is really necessary, and thereby you probably save more lives. And on the next slide, you see the alternative concept. So in any type of major surgery with a predicted blood loss, you should use any blood conservation technique and cell salvage, cell recovery. And this is working quite easy. So if you collect blood in a reservoir, and this is probably happening in almost every surgical procedure, but if you try to reuse and retransfuse this blood, you need anticoagulation. You put heparin into the reservoir with the suction process, and then in the next step you see if you use a cell salvage device, whatever you have in your hospital, you can wash, you can prepare patients' own blood, And on the next slide, you can see that you might be able to produce a patient's own red blood cell concentrate by his own blood, and this can be used for retransfusion. And what you can see here is that collecting blood in a reservoir has roughly a hematocrit of 10 or 15 and is diluted, but by using a machine, you are able to get a concentrate of red blood cells, and this has mostly the same quality as an allogenic red blood cell concentrate, and thereby you can increase hematocrit, you can increase hemoglobin of the patient. This should be the alternative, and this should be standard in major surgery or where you have blood loss higher than 500 milliliters to 1000 milliliters to avoid unnecessary blood transfusion. And on the next slide, you see some data from our hospital, from our study in Frankfurt, where we looked at the quality of cell salvage and red cell separation process. And on the left side, you see the hematocrit of the blood within the reservoir after collecting. And hematocrit is low, but this was predicted. And what you can see here, you can measure the hematocrit in the central lab, or even there are some devices that can measure the hematocrit during collecting and during processing. And on the next step, you see that after washing and after cell separation process, you are able to increase the hematocrit up to 70, 80%. And this is really similar to the allogenic red blood cell unit. And this washed red blood cell unit now can be used for retransfusion, and the patient receives his own blood back after surgery or during surgery. And on the next slide, you also see that the cell salvage devices, they are able to produce red blood cell concentrate, but they are also able to wash out and to remove all the other elements and factors and cells that are not wanted. So here you see that using a cell salvage device, you are able to remove potassium, you can remove protein, albumin, you can remove heparin, free hemoglobin, and you can even remove leukocytes and platelets. So to summarize these data, you can see that cell salvage devices that are on the market, they are able to produce a red cell concentrate without all the other elements, and they are able to remove all these things that you are not probably want to retransfuse to your patient. And on the next slide, you see some important indications. And cell salvage is mostly used in major orthopedic surgery, in major vascular surgery, in cardiac surgery, in liver transplantation, in trauma, and in other type of surgeries. And you see there is really a broad spectrum of surgical procedures where cell salvage should be standard of care to collect in the first step and then to process and to wash and to retransfuse patients' own red blood cells to avoid allogenic blood transfusion. And on the next slide, you see our data from a meta-analysis summarizing all the available evidence published in the last couple of years in terms of the clinical benefits of cell salvage and potential side effects. And on the next slide, you can see that putting together all the trials, we found out that using cell salvage, you have less patients with allogenic red blood cell units. And in the next step, you even see that cell salvage results in less red blood cell units per patient. And in the next step, we could even found that most of these studies found a lower infection rate in the group of patients that received cell salvage compared to allogenic blood transfusion. So really, there's a clinical benefit in terms of reducing red blood cell unit transfusion and there might be even a benefit in terms of infection rate. And on the next slide, you can see that on the global view, if you put together all the available evidence in terms of cost effectiveness, then you see in the next step that putting together all these issues that, the next slide please, that using cell salvage is really cost effective, at least in these patients that you think about one or two allogeneic red blood cell units. And in cases where you have massive bleeding and a higher amount of blood loss, cost effectiveness is more pronounced using cell salvage. So thanks a lot for hearing to listen for the first part, and now can we move to Dr. Samir.
Maybon, we appreciate that so much. Excellent slides, excellent presentation, and then I think you'll be doing a second part to yours after Dr. Samir. Dr. Samir, we have your slides queued up, but before we turn them on, since Dr. Maybon was so kind to tell us a little something about himself, and I introduced you, but I think the introduction is never adequate. Can you tell us something about yourself?
I'm a cardiac anesthesiologist and a critical care attending, and I have my passion is transplant and MCS and ECMO.
You know a lot about ECMO. That is very true. And what about telemedicine?
I have to say, a new and upcoming telemedicine, which is sweeping not the U.S. only, but the whole world.
Mm-hmm. And your experience with autotransfusion, just very quickly, you have a lot of experience with this beyond just the operating room. So
Absolutely.
You really advocate for this on a broader level in critical care.
Absolutely, which is not really something widely accepted so far, but I don't think you should hesitate. People are afraid because they don't see it in the ICU. They're not used to it. But just think about it. All this patient's blood that goes in the chest tube, that goes into the garbage, we can salvage it and give it back to the patient.
Mm-hmm. Excellent point. Okay, so Dr. Samir's slides are ready to go. Thank you, Dr. Samir.
Thank you, sir. Well, thank you, everybody, for having me here today. We're joining our agenda here quickly. We'll talk about the indications, post-op use, ethical issues, blood shortage in the U.S., why it happens. So what is cell salvage? Very quickly. I mean, I'm just again getting the blood from the field by active suctioning, using hard suction catheters or NG tubes, for lack of a better thing, in the ICU. Intraoperative blood salvage, we want to get this blood and give it back to the patient. Obviously, we all feel it's less harmful than allogeneic RBCs. And here's the advantages: reduced risk of infection, no risk of ABO compatibility, and special groups, Jehovah's Witnesses, will talk about that. Normal concentration 2-3 DPG, which is important. The disadvantage, there's an equipment cost, disposables, training for people. It's a little complex for people to use it. And if you have a mishap with air or fat embolism, is bad. But obviously, we also are trained to prevent that. So a special consideration is for our population that we deal with in our institution is a Jehovah's Witness. We are a Jehovah's Witness center. So Jehovah's Witness patients, they refuse blood, and they have different categories. Some of them will refuse everything, and some of them will take certain platelets, cryo. So you cannot treat them all the same. They all seek complex medical care, and whether we agree or not, our own biases, well, they refuse blood, they want an organ transplant. And again, our own bias should not go into play. It's a patient that wants you to take care of them. You have to take care of them the right way. And so you have to go over what transfusion alternatives they have, and cell salvage is mandatory for these cases, whether how small it is, whether a small femoral artery repair or heart bypass or a transplant. So it's really important to salvage all these cells. And there was a question before, if we salvage 20 cells, should we give it back? Absolutely. 30 cc, should we give it back? Absolutely. There should be no minimum with Jehovah's Witness patients. They have no other choice. The other choice is they're going to die. And we cannot accept that. We have to provide them the same quality of care we provide everybody else. So here's the most important thing we have to understand with Jehovah's Witness patients, that the blood is okay for them to get back as long as it's continuous. And we're going to show that, we see the diagram later on, how we connect it. And you can do normal volemic hemodilution. If it doesn't stay connected to the patient, that's okay. HD and CP bypass is okay because it's still connected to the patient continuously. So if we take normal volume dilution, we take a couple of units off, replaced by saline or albumin, if they're okay with albumin, and then we can give it back again at the end of the procedure. And we're going to talk about, we're doing transplants, and we're going to show here a family that had lung transplants from us, or they're all Jehovah's Witnesses. And we have one of our surgeons who specializes in that. On the upper right-hand corner, I want to show this consent. It has no blood with an arrow across it, so really nobody can make a mistake. Even when we put on the board, we identify them, which is sometimes controversial, as a JW patient with no blood with a line across it. So nobody makes a mistake, because the mistake for them is like death, equals death. They would rather die than get blood. And I always have the conversation with them. You have to have a very honest and blunt conversation. Nothing wrong with that. And again, we were able to transplant those patients safely, and they were survived and went home, and they're doing very well. And we have steps. We get their hemoglobin up and hematocrit up pre-op, apogen, everything, iron, everything else. And here's some of the setup, how we keep it continuous. And then we're going to see here's again, we put if it's a peripheral 14 or a cordis, and that's hooked up with a tubing to the bag. We're collecting from the chest or from the wound, whatever it is, and we will either infuse it continuously if it's high volume, or the washing depends on. The most important is there's no discontinuity of the line at no point. This can come out, come out and shake it, do anything with it. You have to keep it going continuously. It has to always be attached to the patient. Same thing if you're in the ICU, you have your suction catheters in the chest, hard or soft catheters. You're sucking out the chest and giving it back to the patient continuously. No interruption whatsoever. Again, same here. So clinical benefits with cell salvage, reducing hemolysis, high hematocrit reinfusion, and improved outcomes. Although we're going to talk about there's no reduction of mortality. This was a study from Landau. We're just going to go a little more. So Landau in 2018, he compiled the first data on performance and outcome, and that's amazing. That's only 2 years ago. And that tells you cell salvage, although we've been using it, we haven't looked at it on hold for a long time. Why is that popular? That's something we're going to discuss later. Is it because people are afraid of it? Is it because of cost? Is it because of equipment? Lack of familiarity? I'm not sure. So Landau, we took two cohort studies, out of 2 cohort patients, orthopedic surgery, cardiac surgery, and the endpoints were cell separation, performance, and washout quality. We're going to look at that. The inclusion were age greater than 18, elective orthopedic or cardiac, so no emergency cases. Blood loss greater than 10%, which I'm not sure I agree with. Exclusion was pregnancy, and as we said before, and I got confirmation that when we had a break, there is now, people are thinking of using cell salvage for vaginal deliveries, not just C-sections. And it's a controversial subject, and there's a paper now being submitted for acceptance from OB-GYN for acceptance of that. And there's also the concern about the particulate and having 2 suction setups in the field. Is that going to be feasible? Is that economically better? And for me, you get save blood and give it back is the best thing in life. So what's the German guidelines? And we have I'm glad we have Dr. Maybaum. That sufficient hematocrit between 55 and 75%. That's good quality return. And the washout evaluated for potassium, albumin, heparin, free hemoglobin, white blood cells, and platelets. So they looked at the cell salvage, the hematocrit out of the machine itself and in the lab. And so out of the machine itself, the hematocrit was about 12 with 10 to 14 median. And in the lab was 14.9, 11 to 29 variation median. And p-value was very, that is comparable. And that's the PRC, the concentration 78.5 with 71 to 84. And in the lab 73.7, 67, 75. There's no variation. So it shows there's no variation in between the lab and the machine itself. So you can believe the machine reading. If it's telling you that's the hematocrit and the pre-RC concentration. There was no variability. And now the washout quality. For K, potassium was 92.5, median, minimum 73, 99 max, and you can look at the rest. I look at the K most importantly. White cells, 72.4, 9 to 95. It's an interesting range. Platelets, 94, 63 to 99.
May I ask you, just because I'm going to forget this, but can you go back to the previous slide? So just very quickly, what you're looking at here, just for clarification, is actually the devices that measure the reinfusion hematocrit.
Absolutely.
Going into the
They use the CAT
bag.
Smart. They use the CAT Smart.
Gotcha.
And they use the measure the reinfused hematocrit, which was 12, but they reinforce it by the lab. So we show this the device does work. So the lab showed 14.9, PRC was 78.5, labs showed 73.7.
So very close.
Yeah.
And then the next slide you were at, again, go back to your forward slide.
Okay, so
in this,
the washout quality, you see the potassium removal. The median was 92.5, for the range was 73.3, the minimum and the max was 99.1.
But focusing on the WBCs, because that said, even with the free hemoglobin, how did they talk about and the platelets, did they talk about their technique? Were these full bowls, partial bowls, particular type of machine? Because that is a pretty wide range, from 9 to 95.9.
It is, I have to tell you, for the YBC, I was looked at that 3 times to make sure it's not the wrong number. You know what I'm saying? But it's not the wrong number. It is.
I would have to review that article. I think everyone anyone who reads it should review that to consider what their technique was. And if Dr. Maybaum knows, Professor Maybaum, he certainly during the discussion, maybe you'll make a note of that and we can discuss that. Go ahead. I'm so sorry to interrupt.
No problem, sir. Okay. And again, same graph that Maybaum showed about the removal, just for a graph size. So again, what did the study show from Landau? That we remove sufficient red cell separation and with good washout quality, and this patient getting quality blood back. So, as Dr. Maybaum is going to talk about, it's a whole approach. It's not a one thing. Erythropoietin, iron, okay, pre-op, which is normal for me. Normal volumic hemodilution. Again, you have to do it the right way. If you do not do it the right way, you're going to lose the blood. The blood has to come out. Mix it with citrate, special bag, special setup. You have to have the scale shaker so you don't clot off. The worst thing you can do to a JW patient, take their blood off and let the clot outside the body. That's the worst thing ever, obviously. I mean, now infusible oxygen carrying fluids, we talked about it before. There's no final approval. The military is working on it. I'm sure it's going to get approved by the military first, then Europe, and then maybe FDA will approve it here. So the really summary, cell salvage is safe. It's resource saving because the cost of acquiring 1 unit of blood, I just looked it up yesterday, is $1,000. It's not just getting the blood and delivering it with no ABO issue. And if anybody, the Houston audience, we are familiar with an issue that happened in the Houston metro area about an ABO issue. Was a big deal. None of us want to get an ABO incompatible blood. And now every med staff, and I'll tell you something, every med staff to renew their privileges, you have to take an ABO safety exam. That's how big of an issue it was. So anticipated blood loss indication, the indication, actually the published indication is greater than 20%. I really am not sure I agree with that. And maybe I'm too stingy, maybe I'm crazy. I believe you're going to lose blood, use it. I mean, you really cannot estimate what 20% is going to be. For me, I've used it in big cases like transplant and heart surgery, and as small as femoral femoroplasty, any plastic cases. We're going to open anything. You're going to open the vessel, and blood is going to come out. Collect the blood and give it back to the patients. So the indications for the approved indication for the general public is 20%. For JW is 10%. I believe for everybody, you should use it if you think you're going to need it. And that comes with experience. Unless here's the cases like for cardiac valve redo bypass. Ortho spine cases, urology, prostatectomies. And I'm glad I see that today because unfortunately I was consulted on a case of prostatectomy that required 35 units of blood. That was not like too long ago. And that would have been, and there was no cell saver set up in the room for that case. Again, thoracos, liver transplant, JW, we talked about that. I mean, from regulatory you have to worry about clotting agents, avitine getting sucked into it, into the cell saver. So this happens from the field sometimes. This is kind of the problems that can happen. We had a patient that was really deadly allergic to betadine, and betadine got sucked into the cell saver. And every time we infuse the cell saver, we get like a massive hypotension. And so we figured it out after a while. So these things you have to really worry about. Obviously, malignancy, blood disorders, you have to worry about them giving blood back. So here's Dr. Maybaum's meta-analysis, and I'm glad we have him here. Please come, Dr. Maybaum, on your meta-analysis if you have anything you would like to add. And he did an amazing work. We're going to go over what they did. They looked at all surgery type, randomized to either a control group or no salvage group. And the data was the risk ratio. They looked at the median differences. They looked at the number of patients who were exposed to allogenic RBCs. They read 1140 search results. 47 trials were included. After they looked at 1140, only included 47. That's amazing work. And the savings was 0.2 units of allogenic RBC per patient reduction, 28% reduction risk of infection, and 2.3 days reduction in hospital length of stay. But again, did not reduce risk of mortality. Because, and Dr. Maybaum had answered this before, that this was one intervention only that would not affect risk of mortality. And no statistical differences observed in patients exposed to reoperation plasma or platelets, or rate of MI or stroke. Again, it's one maneuver only. So based on this meta-analysis, which is an amazing meta-analysis, the biggest comprehensive meta-analysis for cell salvage, watched cell salvage efficacy in reducing need for allogenic RBC transfusion in surgery and decreasing risk of infection. And I would recommend it for everybody. You think about, and I'm going to talk about, think about use it, use it. And this is just some of the slides about the study. We're going to go over them quickly because I think everybody knows the study. We're lucky that Dr. Maybaum here. And now this is the guidelines that came up from England about when to use cell salvage by Dr. Klein. And we're going to go over some of these guidelines because I think these guidelines are very important. You know, I mean, should we use it? Yes, whenever, you know, expecting blood loss, yes. Here's the one thing which, again, I disagree with. If you're going to lose more than 500 mLs or 10%, I think you should use it if you know your surgeon. You know your case. It's your experience come into play. You think you want to set it up. I never said, I'm sorry, I set it up. I said, I'm sorry, I did not set it up. I've always thought, why did I make the decision to set it up? I never regretted setting up cell salvage. So I'll have to say I'm a little biased here. So obviously, malignancy infection should not be using cell salvage. Now, we see here there's about not use it with the OB. What we just talked, there is people want to use it for vaginal deliveries, not just C-section. And again, we would think having 2 suckers on the field is very important. And this is again recommendations from, you know, in 2018 about not using it for C-section. But again, I think this is all going to change now. Now, COVID-19. What happened with COVID-19 and blood donations? And I'll tell you, this is a very real experience in Houston. Obviously, we're one of the high numbers for COVID-19 in the country, and we do a lot of cardiac surgery, transplant, and we use a lot of blood products. Our blood bank was seeing severe shortage, like beyond severe. And I'll tell you, the shortage was because people don't want to go to the blood bank, and we have to social distance. And the blood bank is busy itself with doing convalescent plasma. So you have two issues: convalescent plasma by the staff occupying the blood bank, which is one of the big treatments that we're using in Houston. And people don't want to go to the blood bank to donate, and they're afraid. People are afraid to leave their house. They have to social distance, shelter in place, and you cannot blame them for not leaving their house. We put out a lot of calls for blood donations. We had to cancel our electives and scale back. But you have to remember, you can cancel your electives as much as you can and scale back. People are still getting sick. People requiring emergency heart surgery. I mean, the transplants were actually stopped at some point. Unless you get, but can you imagine? So now here's the issue. You're getting an amazing organ, but you're not doing the transplant because you don't have the blood product. That's really, I have to tell you, some crazy things. And I'll tell you, so this kept happening one after the other. You know? I mean, really, it was a big, big issue. I mean, that we don't have blood, and the nation's supply is really, really low. So we put, the TMC put out a call and saying, we need blood. And I'll tell you, thank God people responded at some point, and we got blood in May that lasted all the way to July. But you cannot, the problem is, this was a big call, and it was aggressive, advertising from the hospitals on the news to get the blood in. But that's, with now COVID-19 spiking up, going back up every now and then, you're going to have a shortage every now and then. So you cannot rely on the blood donations. You're telling people to stay at home. You want to tell them, no, please come to the hospital. People don't want to come to the hospital. ER visits are way down. Electives are way down. We're doing telemedicine for everything. You cannot do telemedicine to get blood. So I'll tell you, we need to have definitely a backup plan. So every case right now in the operating room that there's a thought that's going to lose blood is having self-salvage set up. We need to save every unit, because every unit is going to save somebody for a surgery that they need. Because it's amazing for us to throw an organ or to let an organ donor go by because we don't have the blood to do elective surgery. I mean, you can say transplant is elective surgery till tomorrow, but it's not really. You have an organ available for somebody who really is dying. So you really have to take care of them. So it's a cascade effect. I call it the domino effect of blood. You don't have blood, but you're going to do a transplant, and you're going to waste an organ. So it's a really big deal. So I have to tell you, it's important for us to this. What was I saying? Okay. So, I'm sorry. I'm saying I'm taking too much time. I'm going to have to go a little faster now. I'm sorry, Jennifer. I'm not sure. So I have to tell you, it's very like having the blood shortage due to COVID-19 is going to keep going on. So we need to put that in our mind. So think about it. For every case you're going to do tomorrow, with a femoral angioplasty or heart bypass. And autologous plasma issue, obviously we know it's a storage issue, hemolysis. So here's a summary: improved outcome, reducing hemolysis, giving high quality PRBC, relatively inexpensive, not $1,000, and you can take care of a lot of different patients. Again, our Houston experience, the post-op experience, I'm going to go a little into detail. I learned this from one of our esteemed surgeons, Dr. Lobi, who's from Germany originally, currently in Jackson Memorial in Miami, where we come out to the ICU with open chest, and those with draining blood out, and we throw it in the garbage. And it was killing me to throw all this blood in the garbage. And you need to get the patient out to the ICU, warm them up, correct the coagulopathy, and then take them back, clean up, and then close again. So I'll tell you, we asked to set up cell-saver bedside. It was a big resistance from the staff. What are we going to do? Is this not the OR? What are we moving the OR to the ICU? I said, yes, we're doing trauma surgery. So we collected it, and we collected 500 and give it back, correct coagulopathy, correct protamine, correct coags. So it was like a multi-level approach. And those patients stopped bleeding. We took them back, cleaned them out, closed the chest. It worked out very well. Now it's becoming a routine thing. And there's no resistance anymore. I mean, cell-salvage bedside in the ICU becoming a normal thing. Actually, I got asked right now, we'll bring an open chest out. Is cell-saver coming out with us or not? The staff now feels bad about throwing blood into the garbage. And they feel that that's not the right thing to do for the patient ever. So we're doing that, and I have to tell you something, it saved a lot of blood transfusion. We feel these patients do much better, and we feel like we're able to take care of them. There's no rush anymore. Warm them up, correct the coags, which is the best thing in life, take them back, and close them.
Saved a lot of lives.
Here's final thought. If you're thinking, should I use cell saver today? Yes, do. If you think about something, do it. Don't ponder. Do it. You're saving a life. Salvage always. Save the patient. Please save my blood. Don't throw it in the garbage. You're throwing part of my body in the garbage. Think about it this way. Thank you, and I'm sorry, Jonathan, for taking too long.
You did a great job. You did a great job. I'm going to applaud this one. You did an excellent job.
Thank you.
Okay, Dr. Maybaum, I think we have your next slides teed up, and I know we have a tremendous amount of Q&A stuff going on in the background. I noticed that you're keeping track of that and doing a great job with it. The nimbleness of being young. I can't do technology that well, but your slides are ready, and the floor is yours, sir.
Okay, thanks a lot. Thanks, Dr. Samir, for some of the ideas. So I wanted to mention the blood shortage too, so you can just jump to 1 or 2, 3 slides because they're just press releases. So in the next one, yeah, so here we have data from 2 German university hospitals and what happened in March and April this year. And what we observed that during lockdown and cancellation of elective surgical procedures, the type of cross-matching, number of cross-matching is going down. But on the next slide, you see that the total amount of allogeneic red blood cell transfusion is still high, or is probably the same as before COVID-19. So what you can see here, even if we reduce elective surgical procedures to get ICU beds and all these ventilator beds, in terms of allogeneic red blood cell transfusion, there's no change, and consumption is still high, and that's probably one of the reasons that we really need alternatives, and there's really an urgent need to avoid unnecessary red blood cell transfusion. And on the next slide, you see 2 articles focusing on this topic in terms of COVID-19 and patient blood management. And this is really a broad program, multimodal, including cell salvage, where we try to keep an eye on patient, where we try to improve hemoglobin levels and to avoid unnecessary blood transfusion. On the next slide, you see that the WHO has already recommended and suggested that blood sparing techniques should be in place to improve patient outcome and to reduce costs. And on the next slide, you see that there are national concepts in the United States, in UK, in Australia. And on the next slide, you see that even in the European Union, we have really global guidelines, programs about patient blood management, and the idea to avoid unnecessary blood loss and to avoid unnecessary allogeneic blood transfusion. And on the next slide, you see the most important issues and measures, and we are focusing on anemia management, and we are also focusing on rational and restrictive blood transfusion. But the most important part of patient blood management is minimizing blood loss and minimizing bleeding. And of course, we are thinking about coagulation diagnostic and coagulation management, but intraoperative or perioperative blood salvage is a key element to avoid unnecessary blood loss, to avoid and to reduce bleeding, and thereby to avoid allogeneic blood transfusion. And on the next slide, you see, just go forward 1 or 2 steps, then you see again a summary of the recommendation, and again, to repeat the most important issues. Cell salvage should be used in any surgical procedure where you expect an increased likelihood of bleeding and transfusion, or where you expect post-operative anemia. And cell salvage should be available 24 hours in your hospital. And you see that you can have a 2-step approach. You just collect blood in a reservoir, and as soon as you expect 500 milliliters or more, you just go for cell processing and washing. And also in the next step, you see that if you talk to a patient, if you get a consult, and if you talk about the potential risk and benefit, you can use cell salvage in cancer surgery, and of course in women undergoing high-risk cesarean section. And on the next slide, you see if you put the cell salvage technique into a multimodal program defined as patient blood management program, and if you're focusing on hemoglobin optimization and blood sparing techniques and transfusion protocols, and you see here you can reduce blood transfusion, you can reduce postoperative complications, and these are data from 4 university hospitals in Germany. And in the next slide you see this concept is working worldwide. And on the next step you see really a patient blood management bundle focusing on anemia management, on coagulation management, but also focusing on cell salvage and cell recovery during surgery. You see in the next step that thereby you are able to reduce allogeneic red blood cell transfusion need, you can reduce in-hospital mortality, and thereby, of course, you can reduce costs. And on the next slide, you see that, I mean, patient blood management is and should be the standard worldwide. And we have summarized 17 large PBM studies, trials from United States, Australia, and Europe, and we are focusing on multimodal PBM programs. And then in the next step, you see that if you include cell salvage in a PBM program, and if you focus on anemia management and coagulation management and transfusion medicine, then you see in the next steps that thereby you can reduce allogeneic red blood cell transfusion rate. There you can reduce major complication rate, and then you can reduce mortality rate. And on the next slide, you see that cell salvage should be really the standard of care in major surgery where you expect blood loss, but of course you need time to teach your team, you need time and afford resources to teach colleagues and to put efforts in the infrastructure. And therefore I would really recommend the information and details provided by the UK Cell Salvage Action Group. And here you see a screenshot where you really can use an e-learning platform and all the details that are necessary to implement a cell salvage program in your hospital. Thanks a lot.
Excellent. Very good, Dr. Maybaum. Thank you so very much. All of those lectures were incredible, and I want to thank both of you gentlemen for that. I know there's been a lot of Q&A. I would like to turn this over to our Zoom moderator, if I may, Jennifer. And Jennifer, if you would, just a favor, would you please describe first, before you maybe ask any of the questions, about Gary Koenig, who started this off with, I thought, some very important information as well. You want me to do it? Okay. So Gary Koenig, in, I believe he's from South Carolina, Spartanburg, South Carolina, writes, with our post-heart patients, we have developed a way to transfer blood from the chest tube drainage system to a cell saver for processing for the past year, and have saved the department more than $150,000 with blood that was thrown away in the past. We also are a Jehovah's Witness network program. I thought that was incredibly powerful, goes to everything that you said, went to everything that you, Dr. Maybaum, said, and very, very, very impressed by this. So now I will turn it over to, first I'll let you guys maybe comment on that, what Gary had to say, and then we can go on with some questions from our moderator. Dr. Samir?
Well, Gary, I'm really glad to hear this, because now I feel I'm not alone in the world. I feel there's somebody else doing the same thing, and it really makes me feel good. So I really appreciate your input.
Dr. Maybaum, you have any comments?
Yeah, congratulations to this guy, to this team who has had this success.
Okay. So if I may, I have several questions, or no, our moderator. So go ahead, because I can ask questions all day. So Jennifer, you have to take over. You have to take over from me because I won't stop asking things.
Have you or your team utilized salvage of red cell mass in saturated surgical sponges of a heparinized patient?
Okay. Can you say that again a little louder?
Lap pads, soaked lap pads.
Oh.
Yes.
Regarding the question on using
Yes.
blood
This
from
is-
swabs.
Yes, yeah. Soaked lap pads. Have we ever used the soaked lap pads?
Yes.
And okay, may I answer?
Mm-hmm.
Yes, absolutely. We've done that. It's a controversial situation, but yes, we have done that.
Mm-hmm. Dr. Maybaum?
Yeah, I personally know surgeons who use swabs and sponges and just press on the sponges to get and to save every drop and every cell. And it depends on the team, and it depends on, but I argue and I emphasize that collecting blood by the suction is probably more worse and less traumatic to the red blood cells itself. So, but before you just waste the swabs, yeah, try to get and to save every red blood cell.
Absolutely.
I think so too. And if I may, I read an article not long ago, and it was very interesting how you can take a red blood cell as long as you maintain it in a suspended state, and you can subject it to tremendous both negative and positive pressure, and it will deform and stretch, and as long as it's a viable cell, and eventually it will, when you relieve the pressure, it'll go back to its normal shape. But when you add an air interface, so Dr. Maybaum, to your point you just made, when you add that blood air interface as you do in a suction, it becomes very problematic for a red blood cell. They become very fragile and just don't like it. In the lap pad incident or technique, I do believe in that as well. I think laps, the big laps, can hold an enormous amount of blood, but I don't like to see them take it and just squeeze it. I'd rather see them put it in a basin of saline and let it soak out, wet it, and then agitate it maybe gently, and then suck that into the cell saver is what my preferred method is. I think it's just surgical diligence, really, surgical technique and diligence. That's my thought. What do you think of that?
I think, well, either way, I'd rather not lose it at all. I agree with your way, but if it's going to be squeeze it or lose it, I'd rather squeeze it.
Mm-hmm.
I do not want to lose it.
Mm-hmm.
Okay.
So you'll accept the squeezing, but would you prefer them to soak it and do it that way? Do you think that's a bit more, a little less
Gentler. It's gentler.
I think so.
Yeah, but the only thing is you
More
cannot change
sophisticated.
surgical habits. It's very difficult to change surgical habits.
Mm-hmm.
So to be honest with you, if they're going to squeeze it and suck it out of the bucket, it's okay.
Mm-hmm. Dr. Maybaum, your thoughts on that?
Yeah, I fully agree, and probably it depends on the type of surgical field and theater. Yeah.
Okay. Jennifer?
All right. Are there any requirements before using cell salvage during a massive trauma with an infected surgical field?
Ooh.
So I'll start with Dr. Samir. Go ahead.
If you are in a massive trauma, and you really cannot assess infected, not infected, you need to go for the gold. Get all the blood that you're losing and give it back. And yes, there's gonna be a chance there's gonna be an infection, but you're gonna have to deal with that later. In the trauma, there's no time to think, to be honest with you. Cell salvage, give back, and then you'll have to deal with the consequences later. Basically, you have to be quick on your feet.
Dr. Maybaum?
Yeah, I tried to remember a patient where I had a massive trauma, but also an infectious organ or infectious tissue situation. So probably, I'm not quite sure if this government is thinking about an open fracture where where we talk about a non-sterile fracture, but as long as there is no ongoing infection and with increased inflammatory mediators or contaminated fluids, I fully agree. Go for cell salvage and keep an eye on patients' own blood.
Hey, Dr. Maybaum, could you just move to your, there you go, a little to your left. That's perfect. Thank you. You look great now. Thank you, sir. No, I think that it's, you know, I mean, that's, I didn't quite understand the question, but, you know, you're in a wound. I mean, it's okay, so you didn't get to make such a nice prep for the patient. At that point in time, I agree with you, Dr. Samir. It doesn't make any difference. Patient's bleeding to death. I mean, you got to deal with the immediate problem first. And you will run out of blood. We have done that before. You start giving the O negative pretty soon, and then you run out of that too. And then what do you do? So I think you need it. I'd like go ahead, Jennifer. You have any more questions?
Yeah. So just a follow-up question, still on the trauma
Yes.
space. So, clinicians, some trauma clinicians and surgeons think that cell salvage blood promotes bleeding. What do they need to know about autologous blood and heparin?
Good question.
So maybe Professor
Dr.
Maybaum?
Maybaum,
Yeah.
Professor Maybaum, you want to go first on that?
Yeah, so I also know colleagues who argue against cell salvage because they think that using cell salvage is associated with coagulopathy. And this might be true if you have a patient with major bleeding, ongoing blood loss, but because you are using cell salvage, there is no need or only a little need to use red blood cell units. And in this way, you probably underestimate the amount of total blood loss and the loss of coagulation factors and platelets, and thereby we see coagulopathy. So that's why I always say that the cell salvage system is for the recovery of the red blood cells, and you receive a red blood cell concentrate. But as soon as you have major bleeding, you also need to think about coagulation management, substitution of coagulation factors, transfusion of platelets, and all the other important elements to stop bleeding. And so this is one important issue, and the other one in terms of the heparin. So heparin has a really short half-life time, and we know from a lot of studies that cell processing and washing and using cell salvage, thereby you can remove heparin. So from our point of view, heparin or coagulopathy is not a side effect of cell salvage, it's more associated with the total situation.
Mm-hmm. I think that's I think that's almost commonsensical. Dr. Samir, let me ask you as a follow-up to that. Do you guys have a standard? Well, two things. One, do you use TEG to assess your coagulation, you know, where you are in your coagulation capability of the patient? But do you have a standard of how many units of autotransfusion blood processed and given to the patient before you give you'll say a unit of FFP, before you start thinking about platelets or cryo or anything else? Or do you base it completely on laboratory analyses, and do you use TEG?
We use TEG and ROTA both, okay? So we do not give like by formula, we give based on lab data, and also add to that ACTs, and we correct either chemically or blood products. We're very heavy to use PCCS, and we have used into Concentra. We're very heavy into all that. So I do believe that you have to follow lab, correct chemically, and correct with blood products, both. Mm-hmm. You cannot just correct with blood products. You have to use chemically too. Mm-hmm. Mm-hmm. So like that patient that I mentioned about the prostatectomy, when he went to the ICU, they never was on MCAR because they did not think about that. I don't blame them. But when we went to the ICU, we bolus MCAR, we started an MCAR drip. There's nothing wrong with that. It decreases fibrinolysis, and you can give PCS again in the ICU still. So you have to correct your tag, and or using tag or ROTEM, and also add that to ACT.
Thromboelastography
Yes.
or whatever
Yes.
that's called, whatever the generic name is for it. I really don't know. But Professor Maybaum, do you use TEG there as well?
What
Or
are you
some
using?
version? Do you use some type of thromboelastography of some sort?
Yeah. So in any type, so we have a European trauma or bleeding guideline, and there we have the suggestion, recommendation that in any type of ongoing bleeding and suspected coagulopathy, we should use bedside monitoring of coagulation. Diagnostic. Yes, of course, we use this, and just to decide in the OR or on the ICU what might be the best therapeutic option for this patient.
Absolutely.
Okay. All right.
Jennifer?
Okay. So let's go on to another question. Let's see. Give me a moment. Okay. So what are your thoughts on leukocyte depleting filters for cancer, pregnancies, and bacterial contamination cases?
Dr. Samir, you want to take that one first?
Yeah, I mean, but like I mentioned, we use leukocyte depleted filters on. It does slow the rate of reinfusion, but we use it standardly unless the patient we have to give the blood back immediately. There's no washing, so we use it standardly. That's becoming for us because we do a lot of transplant. That's why we do leukocyte depletion. That's the reason.
Very important for the
Yes,
white blood for
exactly.
the leukocyte depletion. Yeah.
Okay.
So do I believe it helps in the infection situation? I'm not sure about that. But for us, standard for the regular cases, yes, I do believe it helps.
Mm-hmm.
Okay.
Dr. Maybaum?
So leukocyte depletion filters are not quite important in our country as cell salvage in cancer surgery is not allowed unless you use radiation. And I personally have not much experience with use of leukocyte depletion filters, but I know from an experimental setting that it's not quite easy, and you need teaching and learning sessions how to use and how to think about the blood flow and the how to handle all these issues. So for some patients this might be an option, but most of surgical procedure that I presented, there's no need for any leukocyte depletion filter.
Mm-hmm. Well, I have just a little bit of experience with these types of filters, and my only concern, I guess, for the questioner in this particular case, is that it does make, now in transplants, if you don't have to get the blood in a hurry and you're giving it back over time,
Unless you
it's
put a
fine.
hole.
But it is very slow. So you're gonna, if you really volume back into the patient, it's very difficult to do with the leukocyte depleting filter. It's going to be a slow process. That's the real limitation to it as far as I'm concerned. Jennifer, I'm sorry?
Nope, that's very good. Okay, so aside from HIT patients and heparin-sensitive patients, are there any advantages to using ACDA versus heparin as an anticoagulant with the cell salvage device?
Excellent question. Dr. Maybaum? Oh, you're muted.
Sorry. I'm not quite sure what you mean by ACDT.
ACDA.
This is a type of
ACDA.
anticoagulant?
Acid citrate dextrose, ACDA or CPD, same thing.
Okay.
So like
I
what
got
you
it.
use for collecting blood.
Yes, I mean,
Calcium chelating.
yeah. And probably this is, okay. Yeah, it is possible, and I remember one or two patients within the last 5 years in our institution, and therefore we have a separate SOP for that, how to concentrate and how to administer and how to do the doses and so, but it is possible.
Mm-hmm. Dr. Samir?
I'm not sure there's an advantage, to be honest with you.
Well, I mean, and if I may, hope you don't mind, but we use in many places, we use ACDA that are non-heart patients. If they're heart patients, generally speaking, we're giving them heparin. We'll go ahead and use heparin in the cell salvage system. But if they are, for example, if they are a HITS patient, we'll just convert it to ACDA, and we'll use Angiomax or something like that. Other than HIT?
Yes.
Other than HIT, no, except I think that if the patient is not going to be exposed to any heparin during the procedure, and you can avoid a heparin exposure in a patient, yeah, I think there's actually a benefit. I think there may be a theoretical benefit anyway, because they do say that HITS can be a secondary, your second exposure is much worse. So, I like using ACDA. I think it works very effectively, and it's easy to use, and we like it. We use it for liver transplants. That's what we use. We don't use heparin for those. So I think it's a good option, frankly.
Okay.
But that's just my opinion. Not that anybody asked or anybody wanted to know.
Okay.
But I volunteered to do this. Jennifer, go ahead.
All right, we have a few more minutes. So I'll direct this question to Dr. Samir. Is the cell saver being used in the ICU from chest tube bleeding, or are you washing it before returning it to the patient?
Well, again, it's always going to be depend on the rate of bleeding. If you are bleeding and there's patients that bleed about 1 liter every 30 minutes, that we're not going to wash. We're going to give back right away. Okay, if the rate of bleeding is slow, we are going to wash and give back. Okay, and I wash and give back every 500 ml as usual. But if there's a patient, I'm fortunate to use that expression, hosing out 1 liter plus, we're going to give back right away.
Dr. Maybaum, is that your experience as well?
Unfortunately not. So in our country, it is not allowed to retransfuse any unwashed blood. So that's why we use a continuous cell salvage device, and thereby you have an extra mode for massive bleeding, and you just get retransfused back with a lower quality and a lower hematocrit. But anyway, we use the washing mode in any case.
Mm-hmm. Mm-hmm. Very good, understood.
Okay.
Okay, very good. Jennifer, any other questions?
One more.
One more, please.
Okay.
We have plenty of time.
What type of quality control do you require for verifying proper functioning of your cell salvage devices?
Mm-hmm.
I think if you have any question, you need to send blood from the cell salvage to the lab, and and make sure and check what the hematocrit is, and check the chemistry of that. Just as if it's the patient's blood, check the chemistry, check the CBC on the blood, and see what the numbers there.
Mm-hmm.
Professor Maybaum, do you want to respond as well?
Yeah, yes, of course, thanks. From my point of view, we should focus on 2 endpoints. So the first endpoint, which is most important, is the production of a red blood cell concentrate, and thereby we should focus on the hematocrit. And the higher the hematocrit, the better the quality. And the second issue refers to the removal of unwanted elements and factors, and thereby we could focus on potassium, free hemoglobin, all these things, to get an idea about the removal of elements that are not wanted within the concentrate.
Okay.
Excellent. Jennifer?
Okay. So last question. Should antibiotic be given to a patient when cell salvage is going to be used to reduce potential infection?
That's an interesting question. Who wants to take that first?
I mean, well, to be honest with you, routinely for every case in the U.S., antibiotics are given. Well, that's right or wrong, that is the case.
For surgery, not necessarily for autotransfusion.
No, for surgery. That's
right,
what
it's
I say.
given prophylactically.
Yeah, given prophylactically. So that is happening anyway. So you really cannot say, oh, we're going to give or not give today depending on the use cell saver. Because routinely for every case, antibiotics are given.
Mm-hmm.
Okay.
So, Professor Maybaum, is that your experience as well? You prophylactically give surgeries, any open procedure, antibiotics?
Yes and no. So we defined specific surgical procedures where we use antibiotics about 30 minutes before skin incision. But at the time point where we think about cell salvage, this has nothing to do with any antibiotic. So a repeating dose of prophylactic antibiotics is more related to the time of skin incision and blood loss, and to avoid and prevent wound infection. But this has, at least in our country, nothing to do with cell salvage.
Yeah, here either, yes. I think we all agree with that. Yes. Jennifer, anything else?
I think we...
Is there a last question?
I think we have gotten through them all.
Okay, good. So if I can ask a few questions, I've really bitten my tongue hard. I'm really only going to do one. And I'm going to ask both of you to answer the same question. And that is that in 2020, 2/3 of the way through it, 3/4 of the way through it, almost 2021, why are we still having this discussion about the standard of care, routine use, whether it be set up and collect only, in case you bleed, whatever it may be? We'll call it autotransfusion standby, you call it whatever you want. Why in 2020, nearly 2021, are we still having this discussion? Dr. Maybaum, I'll let you go first on this.
So this is an easy question, but from my point of view, there are multiple reasons it could be answered. So costs and comparison between allogeneic red blood cell transfusion and cell salvage might be an issue. The time to get a transfusion, so at least in our country, it's more easier and it's faster to ask for an allogeneic red blood cell transfusion instead of preparing this cell salvage device, managing the cell salvage device, taking care of the quality measurement. So this could be an option, and this could be the reason. And there's also the issue of anxiety and barriers in terms of infections and cancer and all these issues that are there, where there are no reason that these should play a role. So it's more that we should encourage people, physicians, to use cell salvage, at least, and this is most important, in times where we have less blood donations, and it's really important to avoid the unnecessary allogeneic blood transfusion by using cell salvage.
Dr. Samir?
And I think, again, it depends where you are, regional or an urban, suburban. It's training, it's availability, it's cost. I mean, again, you've got to, not everybody's TMC. There's hospitals in the periphery, they cannot handle the cost of having somebody on call. There's a cost of having somebody on call, there's a cost for the equipment. So for them, get blood anyway. But I have to tell you, unfortunately, I'm familiar with institutions. If they need to get blood, they have to fly it. So there's a cost there. So people have to really think of cell salvage as a substitution of all that. So I think there's also a lack of education. So I think more education. A lack of education part of the medical staff and on the public. The public doesn't know that they can use their own blood still. I think that's a big message should be out there.
So in sort of an industry supported public service PSA, public service announcement type of campaign,
exactly.
Or educational programs like this,
absolutely.
Which I think are open to a very broad audience. So absolutely. We have it for, of course, medical professionals, and a lot of this information is, it's pretty sophisticated, and a lot of the public may not be able to, grasp all of these things that we're talking about. But I think they grasp enough, and I think services, for example, like the organizations like the Jehovah's Witness organization, if they're watching this, anyone from there watching this, are going to take stock in Dr. Maybaum's philosophy, your philosophy, and where you are, and they're going to gravitate those directions. But me, I'm not a Jehovah's Witness, and if you can have take care of me and not give me allogeneic blood, I'm going to be really happy. If I need it, I need it, and sometimes you do, and I recognize that. But if you can give me 1 unit instead of 4, or you can give me 2 instead of 10, I'm still going to be happy. I may not be happy with the 2, but I'm going to be happier than if I got 10.
I mean, I say it, why are you throwing part of me away? Is it necessary to throw part of me away? That's what I say.
Yeah. Well, I think a lot of people recognize now that red blood cell transfusion, allogeneic red blood cell transfusion, is actually a tissue donation. It isn't just a benign, innocuous thing that you're giving to somebody. It's a living cell, and you have to treat it as such. So, managing it, controlling it, reducing it is very important. Dr. Maybaum, you brought something up though, and you said the word cost. I think you even used the word cost. Both of you did. Look, at the end of the day, we're all on the same page here. Given what we understand to be not the raw acquisition cost, but the actual cost when you go through all of the processes of delivering a unit of blood into a patient, everything that has to happen from the time the order is given to the time it's actually infused. What is your assessment? And I think you had a slide on this. What is your assessment, Professor Maybaum, on how many units of allogeneic blood transfusion do you have to not give a patient to offset the cost of delivering the same service with autotransfusion?
Single unit.
Single unit. Dr. Samir, you agree with that?
Absolutely.
So, I think that the evidence speaks for itself, and I think this is an evidence-based issue. It's not a guess by it's not an educated guess. It's not us being, pontificating from our experience or anecdotal. I think there's a tremendous amount of evidence out there that supports exactly what you two gentlemen have just said. Dr. Maybaum, before we leave, what time is it there? What time is it where you are? And can you move left a little bit? You lean right, no,
22.
left. Yeah, 2:32?
Yeah.
2:32 in the morning.
No. It's midnight.
midnight. Okay, because for a while there, this beautiful scenery behind you, I was like, man, that's a heck of a view out of your window. Can you tell us a little about it, though? It's beautiful.
Yeah, I'm living in Würzburg, and Würzburg is located at the River Main, and people who are living in Würzburg, they love to enjoy and to walk around and to drink some wine bottles and to enjoy their lives.
Very good. I think that sounds outstanding. And so, Dr. Samir, I do believe we did get an invitation earlier in the first program.
Absolutely.
Professor Maybaum, Dr. Samir, and I, and Jennifer and Magic and David over there, we're all going to go pack, and we would love to go tour that vineyard that's right behind you and enjoy some of those bottles of wine, because I think we all enjoy that. And hopefully one day, if COVID goes away, which I hope it does, we get a vaccine, whatever's going to happen with this thing, that we can invite you to come here and be in the studio with Dr. Samir, myself, Jennifer, and the guys that are running all of the stuff in the background over there. So hopefully you'll accept our invitation as well. And that's it. Any final thoughts, Professor Maybaum?
No, thanks a lot. I really enjoyed.
midnight. You ready to go to? Are you going to go to bed?
I think so. Yeah.
Do you have
go
to work
home and then go to bed.
Do you have to work in the morning?
Yeah.
Oh, that's miserable.
In about 5.5 hours. Yeah.
That's plenty of time.
But I really enjoyed. So
you're a cardiac anesthesiologist.
Not a problem.
You're anesthesia. You don't sleep. Come on. Dr. Samir, any final thoughts?
Dr. Maybaum, you don't know, but Germany is one of my favorite places. Berlin and Munich is like my second home. And I'm for German soccer all the way. So I just want to let you know that.
Well, I'm going to tell Dr. Lumsden that.
Absolutely.
Well, I can tell you this much, okay? So I know you call it football there. I guess, do you call it football there or soccer?
Football.
Football there, yeah. So I'm sorry, it's like watching paint dry. So you gentlemen enjoy your German soccer, and I'll have to watch a football game. So good night, everybody. It's been great program. Don't forget to go to the QR code, and make sure you do the evaluation. And also, please, are you going to put it up again, David, or can you? We're going to show it at the end, so please do the evaluation. It's critically important that you do that. And we want to once again thank Haemonetics Corporation for their very generous unrestricted educational grant. We want to thank Professor Maybaum for toughing it out until the middle of the night when he going to get no sleep and get up the next day and go to work. And for Dr. Samir traveling all the way up here to where our studio is from where he lives down in the Texas Medical Center.
It's a pleasure.
And I just want to thank everybody. Hope to see you on the next program. Keep an eye out for it on our special series on PerfWeb. Good night and be safe.